Yeah, I mean, it often seems that the people who've suffered brain injury are really keen to talk and engage. Although it often seems that the people who are actually in the medical establishment, yeah, especially with respect to movement recovery,
Hmm.
or movement rehabilitation rather, nobody wants to talk to you about anything. They just see it as a dominance dispute, and
Mm.
it's really disappointing.
Well, that,
Especially because it's not about who knows more or who's the better rehabilitation therapist. It's about people putting their lives back together. You know.
yeah, absolutely. And I mean, sadly, I love what you just said because I have experienced that with cognition and other forms of rehab, and I'm on like I
Yeah.
don't know, loop four, loop five of this.
Yeah.
The latest example is like I had tried to go back to school, and I was like talking to these therapists, and they're talking whatever they're saying. I'm like, you're not saying it right, and it's really funny because yeah, so I've seen this and I've been through this. So
Yeah. I
um
mean, ironically, every medical practitioner who I've talked to about the stuff I do and the approach that I use, all of them are extremely enthusiastic. They say it makes perfect sense. And then when I show them the evidence of the people I work with, people like Timo, they're blown away by it. All of them, except anybody who works in movement rehab. As soon as you're talking in their area, it's la 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 la. They are not interested. They say just treat it as a dominance dispute.
wow.
I've you know, I mean, I'll touch on it later in my talk, but I've twice presented at the World Congress for Neuro Rehabilitation, and I've just been completely ignored both times.
Yeah,
Um,
yeah. So
you know,
I wrote in
um,
my notes la 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 because
yeah.
and why are they doing that? And it's so there's like an ego part to it, and then there's like a
Well,
listen like I don't know what it is, but I've heard so many people explain that, and then it's not about that. It's about what you're doing, and yet
mhm,
that's like a hurdle or a I don't know some problem that needs to be discussed because otherwise it's not going to get to
yeah.
the core of what we even want to talk about. If you're cool, I think we should just get started and people will jump in. And anyone has questions, you can put in the chat.
Well, what I'm going to talk about, I mean, and we can go off on whatever tangents we wish rather,
Yeah.
is it's about the classic approach to movement rehabilitation, following brain injury, and why that has such poor outcomes. And then I'm going to use both the story of my own experience with brain injury, and the work I've been doing with something called the Movement Project. And that has shown that these outcomes aren't inevitable. And what's more, even when classic rehabilitation strategy has already failed these individuals, that the outcomes that they're left with, they still aren't final, and that significant and ongoing progress remains possible on a continual and day-to-day basis. Um, so if I go to my story, which is it's one of good luck and bad luck is where it starts. And I'll go with the bad luck, which was obviously having the brain injury in the first place. I had a cavernoma, and it was on my brainstem. And the cavernoma bled and caused a hemorrhagic stroke. Now, a cavernoma is a non-malignant vascular brain tumor, and given its vascular nature, they're susceptible to bleeding. And obviously, the brain is not a good place to have a bleed. And from an evolutionary standpoint, the the brain stem is the oldest part of the brain, and it's also the most eloquent. It's least able to sustain damage, and any damage that it does sustain is really far-reaching in its impact. As a result, of my hemorrhagic stroke, I lost the ability to walk. Speech and swallowing were compromised. I had coughing fits that had twice left me unconscious. I had nearsighted double vision, hemiplegia symptoms down my left-hand side, and I could no longer feel temperature with my right hand or arm. I was hospitalized for 2 weeks, and then I underwent surgery to remove the cavernoma. Now, surgery is just controlled trauma, and further injury and deficit is often going to come along with it. And a rule of thumb is that the longer the surgery, the greater the extent of the deficits that are going to be introduced by the surgery.
Can I ask you some questions, Steve?
Yeah, sure.
How old were you when this happened, or when you had the surgery and the injury?
I was 47.
47. And do you know like the size of what it was?
It will have been recorded. I think the significance, and I could be wrong, I think the significance with the size of a cavernoma is whether or not it will introduce deficits without bleeding. So it's just the size of it within the brain that will cause deficits. If it was causing any, I wasn't aware of them, and I might have put it down to something else. However, I was very fit and active, and I would usually be reasonably sensitive to any compromise in the body.
When these problems hit, it was like all at once or gradual?
Gradual. It was over a period of days. It had actually been 20 years since I'd last gone to the doctors with anything actually wrong with me. So I wasn't registered with a local doctor when I first started getting symptoms. I was vomiting.
Wow.
I had intractable hiccups, which would drive me around the bend. And I started losing the ability to walk. I mean, obviously, I had a really, really bad head. The mother of all hangovers. But I hadn't earned that one, like, for a change. And so that built up over a period of days, and then I think it was the Friday morning when I started losing the ability to walk. And then, to my eternal shame, I think it was the Monday when I actually went to see the doctor, and then they took me straight to hospital. And then by that stage, I was in pretty bad shape. I was then hospitalized for the 2 weeks, and then had surgery to remove the cavernoma. And like I said, the duration of the surgery will usually correlate to the amount of compromise that's introduced as a result of the surgery.
Sure.
If there's such a thing as an average amount of time for removing a cavernoma, which will just be the average that people report, it's usually about 4 or 5 hours. Although the brainstem is an extremely tricky and, as I said, eloquent and sensitive and fragile area. So my surgery was 10.5 hours. After the stroke, I couldn't walk, but after the surgery, I couldn't even crawl. The hemiplegia symptoms I had were now bilateral, and I mean, double vision was constant. My reflexive stability was so poor, or just absent, that whenever I tried to self-support, I could actually feel gravity. If you were ever in a play park and you get on a roundabout and you can feel centrifugal force pulling you off the roundabout, I could feel gravity in that same way. I could feel gravity sucking me to the floor. It was the strangest thing. But it was also indicative of how completely devoid of reflexive stability it was, and any core stability.
I find it fascinating how, because you're describing all these symptoms and you have really good word for it, both the after the surgery and the before, but did it have like this whole, was it like a more comprehensive strangeness or a way to describe this like overwhelmingness to it, or did it feel more like the symptoms?
Uh, the, yeah, man, it's not the most graceful way to explain it. It all sort of started out to say like the mother of all hangovers,
Right,
and
right.
then I just then started getting all of these additional um, deficits that don't usually come if all you've done is had a drink. Um, and then there's obviously an aspect. There's a psychological aspect when you find out what's happened to you. I'd had a lot of medical training um, when I was in the forces. Admittedly, it was all trauma based, but you know anatomy and physiology, and you know signs and symptoms, and you certainly know signs and symptoms of cerebral compromise,
Mhm.
and that's what my gut was sort of telling me. This is cerebral compromise, but then the thing which put it off because I was first of all when I was vomiting, I thought it was a bug or an infection. And then obviously the problem with vision and the inability to walk immediately started going brain compromise. But then when the hiccups came, I was, again to my eternal shame, I was doing a little bit of a Google diagnosis, and vertigo has hiccups as symptoms. So I was thinking it was an ear infection, and that's where the vestibular compromise was.
Right.
And but I had that thing nagging at me. But then when you find out that like that is a little bit of a punch in the guts, but then my sort of my approach to it was, well, okay, game on. You know, you've got to stand up to the challenge, and the only person who is going to do that for you is yourself. There can be people who will help you along the way, but as far as your mental approach and attitude towards it's sort of down to me. Now, as well as the medical training, I've done a lot of um, sort of sports science training, you might call it, especially with respect to movement quality, both for my own training and physical fitness, and then also the training of others.
What's your background? You should say it here since it's a place.
Yeah. With respect to fitness and sports science, I did 14 years in the forces. I
Mm,
did 2 years with the airborne, and then 12 years special forces.
right.
And then it was within the special forces where I was training myself to maintain and gain the levels of fitness required, and then also as an instructor when I was training others, principally the recruits coming in who were trying to pass the physical selection to join the regiment. And then after I left, while I was in, I found out about the work of Greg Cook and functional movement systems. And then I went over to the States and got certified in the functional movement screen. And I really invested in all of their philosophies. And it was those philosophies which I then used to drive my own recovery, because after the surgery, I was wheelchair bound, and I discussed with the doctors and the physios as to what they planned for my recovery, and I completely disagreed with them. It just totally went against all of my knowledge and my beliefs about movement and movement quality, and also how it can be taught, and that also how it can be restored. Because I can go into that with a story about when I was training the recruits, which I'll touch on in a minute. Yeah, sure.
Because I'm thinking like, what is that functional movement background? But I guess the application you had with the military, I mean, I don't know anything about that special forces training, but I imagine
Well,
you have to learn how to recover from things. You have to learn how to deal with parts of your body in a way that people don't recognize, or
well,
yeah.
to be honest, most of that knowledge was through my own research. Um, and if I'll tell you the story of it now. I mean, so I had a broad basis in sports science just through trying to further my own physical fitness.
Mhm.
Um, and then I was made an instructor on the training team. Now, UK Special Forces, I don't think I'm talking out of turn, is probably the world's most respected Special Forces unit. And the physical test, the physical selection to get in is as you'd imagine, extremely demanding.
Mhm.
And at the time when I was there with the regiment, the pass rate varied between 0 and 1%. Now it's supposed to be hard, but it's unsustainable for it to be that hard. The future of the regiment is at risk. And I was an instructor for the last 6 years of my service, and that was mostly 3 years either side of a tour of Afghanistan. So in those first 3 years, there was just the courses are 6 months long, and for the last five out of the six courses which were in those 3 years, one successful recruit came through. Now, as I say, that's unsustainable for the future of the regiment, and the reason why these recruits were failing, it was because of injury, or the individuals who we'd identified as having the necessary mental and physical attributes you'd associate with success. The reason they failed was injury, but it wasn't falling over and breaking your leg injury. It was essentially chronic sports injuries, knee problems, ankle problems, lower back problems, iliotibial band syndrome. And so when I was away on my tour, I I put a hell of a lot of thought into why that was happening and also what we could do about it. So when I returned, I had an extremely good friend who was a osteopath and sports science guy, also a former international martial artist. So he actually knew himself about the demands of physical excellence and quality movement. He hadn't just read about it. I brought him onto the training team for us to review this. And what we found was that although all of these guys were essentially high performing athletes, they still live in the seated Western world. So they'd started to accrue posture and mobility flaws that are the hallmark of the seated lifestyle. They're all things that you can physically measure and assess. So it was easy to identify them and also to correct them. Mm-hmm. So in correcting them, we got a little bit of an uplift in the pass rate, but not what we were after. But what we realized was just because we reset all of their range of movement so they now could move correctly, they could still move incorrectly. We corrected the hardware, but they were still running on their old software patterns. So although they could do it correctly, they were still doing it in the same way that they did previously. Now it's different for the standard person because they perform and have got way better mechanics than the standard person. But for the special forces selection, the margins are tiny. And so the intensity, frequency, and duration is through the roof. And so these small flaws in their movement patterns, or comparatively small, over the period of the selection, they were all showing up. So what we thought, right, we've got to get them back to factory settings. So we said, well, how do we do that? Well, movement's got a hierarchy of dependencies. You can't exhibit any one skill if there's an absence in the skills it depends on. And we learn these skills as infants, as babies. That's where we learn the primitive movement patterns. And so we thought, if we're going to reset all of these guys back to factory settings, let's get them rolling, let's get them crawling, let's get them squatting. And we did that. And then we changed at 0 to 1% pass rate to over a 50% pass rate. And we were consistent with that. And so that was where all of my founding beliefs and philosophies about movement came. And so when I had all of my movement skills rubbed off me, I knew exactly what I was going to do to reinstate them. And I was at first, surprised, then borderline amazed and disappointed that the establishment doctors and physios just thought the complete opposite. That the first thing they were trying to do was to teach me how to walk. It was going, right, okay, we want to start with walking and get you walking. Well, what about all of the skills that walking depends on? The reason why a baby fails to walk immediately, it's not because it lacks the mental maturity to work out what walking is. It's because it hasn't got the fundamental skills and also structural strength that walking requires. So it acquires them in a natural way. And I can go on to talk about why the baby accrues it in the sequence that it does, and also what it offers to your movement quality. And it touches on the point you made before about learning and relearning, because when you're relearning, you think you've got a frame of reference for what it is you're trying to learn, and then that will dictate and steer the strategies you use for relearning whatever it is. But it doesn't change a dependency hierarchy. Just because you know or think you understand what's on top of the hierarchy, you still need the dependencies for it. An example is, if you had a mathematician whose academic skills were compromised by brain injury, if you tried to rehabilitate those skills, you wouldn't just immediately start trying to teach him quadratic equations or differential calculus. You teach him addition, subtraction, division. And once he was competent in them, you would then go into algebraic techniques, etc., etc. Well, that's the same with complex movement skills, such as walking. And it's as if the therapists view walking as the most primitive movement pattern. But walking's huge and complex. I mean, just as a quick example, and this will also tie in with how the infants learn their movement. When you walk, it's right foot forward, left arm forward. So what that means is your shoulders are pointing over there and your hips are pointing over there. Well, your shoulders and hips are joined by a single spine. So, you always have to do a bit of quick maths when I calculate this. So you've got 12 thoracic, 5 lumbar. So we're doing 17 different vertebrae there, which the top and bottom are pointed in different directions. The spine's got a corkscrew, and if it corkscrews, that means all of those vertebrae are in a unique position. But it's not just they're in a unique position; they've got to retain congruity with the joint above and the joint below. And it's not just that. If you're going to walk, it's also got to dynamically switch to the other way and maintain that congruity throughout. Now, neurologically, that is huge. So if you've got someone who's lost all of their movement skills, and then you stand them up on 2 feet, well, first of all, they're terrified of falling, because a fall can seriously injure an adult if he falls from 5 to 6 foot up. And so he's going to brace, that's going to stop the spine dissociating. So that's why you get the classic stroke walk of the guy walking like Robbie the Robot. And so if you don't teach that dependent skill of the spine being able to dissociate and do it in an environment where it can learn it safely, well, the whole process is going to be compromised. And so that's what a baby learns when it rolls. That's why a baby rolls before it crawls. When it rolls, it turns, looks, and reaches. There's that dissociation that you see in walking, where the shoulders are pointing one way and the hips are pointing another. But the baby does that when it's on the floor, where it can't fall. So it can stay relaxed and feel safe and have expansive movement. And then when it gets to crawling, it starts teaching its hips to weight bear. It also starts learning that contralateral pattern where the arms and the legs are going opposites. And then a really important stage is when it goes from squatting to kneeling. Because when an infant is kneeling, or when anybody's kneeling, well, it's exactly the same as standing from the knees up, except it's a reduced challenge because you've got a lowered center of gravity. And so that's where you can learn how to control a vertical spine while you're sustaining your own weight. And you learn these primitive and dependent skills before you then go on to something as complex as walking. Because I can show you something here. Have I got the ability to share me? I mentioned earlier that I attended and presented at the World Congress for Neurorehabilitation, and it's hosted by the World Federation for Neurorehabilitation. And at the beginning of each congress, they have something called the Clinical Pathways series, where they have classes to teach what is seen as the gold standard or the professional standard for the various disciplines of neurorehabilitation, including relearning to walk. And as you can see here, the accepted belief is that once a brain injury patient is 3 to 6 months post-injury, no significant improvement is possible. And so, first of all, you've got a question around that. And it's as if it's believed that's a limitation of the brain's ability to learn. But in fact, it's a limitation of the strategies that they're using. But I think also that this perception of there being a glass ceiling for progress at 3 to 6 months is also going to encourage people to push the envelope as how rapidly they can advance somebody. And maybe, I mean, this is just me, just kicking stuff about. That's the reason why they're so keen to try to walk straight away. But I'll flip onto another, just for that example. There's another slide that I took from the relearning to walk pathways, and it will show you how it advocates. There you go. And that's the first therapeutic goal is walking. And if someone's unable to walk, then they use walking with help to try to push to independent walking and push it through. And then if the patient fails to walk within those 3 to 6 months, then they're immediately taken to what we call compensation strategies, ways to work around their deficits. And a phrase which I have to be honest, I detest is people learning to live with their new normal. And it's clear how that can be helpful. It's crystal clear how that can be helpful. However, with that comes almost like a level of that you need to have a level of acceptance for where your barriers are. And you absolutely do not. Neuroplasticity, which is the brain's ability to learn and develop new skills, basically. That's there for life. That's not only there when you're an infant. And so if that skill's there for life, why are they talking about this 3 to 6 month glass ceiling? Because another reason for that, I was talking earlier about the consequences of living in the seated Western world and how that impacts even, the most athletic people in the world. Well, just for Joe Bloggs, and particularly Joe Bloggs, who's, I think it's something like 2/3 of acquired brain injury patients are over the age of 40. Now, what standard 40-year-old who lives in the Western world has got anything like authentic range of motion? And when I say authentic, what I mean is consistent with the design of the human body. If someone's lived for 40 years in the Western world, they've got all sorts of biomechanical compromises. And so if you're trying to teach them to walk straight away, not only are you trying to teach them a skill where the dependent skills are absent, you're asking them to do that with their mechanics working against them and not for them. And this is something which, never mind, it's not addressed. It's not even acknowledged that it's a factor in the neurorehabilitation. And so the day before somebody has his brain injury, the likelihood is they already don't have the mechanics to be able to learn to walk, and then they have a brain injury, which is going to be further the challenge. But then also they're going to have, however many weeks of enforced bed rest, which is just going to compromise their mobility even more. I mean, if you have just get up after a long sleep, it can need a considerable stretch and walking around the room before you restore, the mobility you had the day before. If you spend 2 weeks in bed, your mobility is going to be seriously compromised. And if you think you can then learn a complex skill such as walking without restoring your biomechanical relationships, well, that's not going to happen. So I disagreed with the doctors and the physios with respect to what I should be doing, and I signed myself out of hospital still in a wheelchair. When I disagreed, I obviously did it in a respectful way, but I just said, right, well, he said, can you tell me that walking does not have any dependent skills? It doesn't rely on the ability to dissociate the spine or work with an asymmetrical pelvis. He said, no, we can't tell you that. I said, can you tell me that loss of mobility won't impact the ability to learn physical skills? Because you can't learn a skill and a range of movement that doesn't exist. So he said, no, we can't tell you that. I said, well, okay, guys, I'm gone then, because I know from my own experience how I can, how those compromises will set up roadblocks for relearning physical skills. And I will be better off at home crawling around on the floor than I will in a high-sided hospital bed where, it's difficult to move, difficult to get out. And so that's what I did. When I got home, I resolved that I wasn't gonna even try to walk until I'd acquired all of the primitive movement patterns which walking depended on. And so I would spend my day, going from the couch to the floor. I'd be lying on the couch, and then if I wanted anything, I would crawl to go get it. If I was in the living room and I wanted the television controls, I would crawl over to the controls. Now, what this also does, like when a baby is learning its developmental skills, it doesn't sneak off to the gym when its parents are asleep or get visited by a physiotherapist. it lives it's movement education in the same way that a brain injury patient should try to live its recovery. And what I mean by that, for instance, me resolving my movement needs by living my recovery, I would crawl over to the television controls, and then I'd come up onto my knees because I'd need to free up my hands. But then, as I explained earlier, in coming up onto your knees, you're then teaching your vestibular system to cope with a vertical weight-bearing spine with a vertical pelvis over 2 points of support. And that's how you start acquiring all of these skills developmentally. And, you know, if I needed to go to the bathroom, I would crawl from the living room to the bathroom. When I'd go to bed, I'd crawl up the stairs. And I developed all of my movement skills in this way. And within,
Can I ask you about that development
yes,
of how did it feel? Did it feel difficult? Did it feel natural? Did it like progress, or how did
yeah.
it?
So I think anyone can relate to a physical skill that's, you know, the first time they try it.
Yeah.
You know, it's almost like the first, try and pick the thing which most people relate to. If the first time you tried to play a computer game or an Xbox game, not that I ever do, but the first time you try to play it, you're awful at it. And then, and what's happening in the brain is it's trying to build neurological patterns, and then each time you fire a circuit in the brain, if each time you fire one of these patterns, a layer of myelin gets put down, and the myelin makes the pattern easier to identify and acquire, and also it executes it more quickly. And so that means that the ones that you use more often, you can acquire them more quickly, more reliably execute them. And that's how you build your patterns. It's a little bit like if you're going to walk across a field of wheat. Now, first of all, it's just like a sea and there's no tracks to follow. But if you walk across it, the next time you see there, you can sort of identify where you went. That's like the first time you try to lay a pattern down and the first time you try to execute a physical skill. Now, the next time you go over it, it's clearer to follow, and you can move a little quicker on it. And then if you do it time after time after time, well, then it becomes, you can acquire it immediately, execute it quickly. And that's the same thing of developing competence in a physical skill.
Wasn't it frustrating though? And you have said this already before, and you said it in a more general way, but when you're trying to do the thing that you thought you can do, and then there's a psychological aspect to it because it's like I should be able to do this.
Yeah, but that one of the things was there is because of my backstory and my experience with developmental movement patterns. I would only try movements where I had competence in the dependent skills. So I would set my targets according to that. And so, you know, you would keep getting reminded of, you know, of your compromised skills and certain things. And then certainly where that's happened most is after I'd learned to walk. You know, so once I'd learned to walk, you then more immediately go into some really complex skills where it isn't necessarily self-evident what the dependent skills are. And so you can, like a good example was single leg balance. Now, something I touched on before is that movement isn't just software, isn't just the patterns in your brain. It's also hardware. It's the biomechanical relationships you've got. Now, in order to be able to stand on one leg, you need your ankle mechanics need to be in good order, because otherwise all the proprioceptive abilities within the joint they're not going to send the correct and or accurate information or quantity of quality information into your vestibular system. And then also, if those relationships aren't correct, and if your hips or your spine mechanical relationships, well, you're not going to be stacked in a stable alignment. And so when I try to stand on one leg, I would just fall to one side, and I just wouldn't have a frame of reference from the neurological feedback I was getting, how I could correct it or do anything for it. But that started coming when I had physical work done on my ankle, when I got, my ankle range of movement restored. All of a sudden, I started getting information of where I was in time and space and what I needed to do to correct it. And that was just, almost purely physical intervention, which brought that around. And if you think about this idea of taking people straight to walking, you can then see how the challenge they face is just going to be enormous, and how ignoring people's mobility and biomechanical relationships is wow, it's going to place an almost immovable roadblock in there. And so
that figure, that plateau that you show, I've seen figures like that all the time. 2 years, I don't remember the years or months that they always talk about, but it makes a lot of sense that figure is a symptom of the problems of what people get thrown in. Yeah.
But what you'll generally hear is that your complete recovery will be between 2 to 3 years. However, after 3 to 6 months, you get no further significant improvement, and it's absolute nonsense. After my own rehab, I suppose I've got a couple of things I could show you with respect to my recovery. I've got a video here which maybe shows the level of compromise I had immediately. Here's me just after I got home from when I'd signed myself out of hospital, with, as you can see, a rather fetching hairdo I had about myself. That was fairly low down in my order of priorities at the time.
My name's Steve. I had a brain hemorrhage just on 3 weeks ago, or 3 weeks ago yesterday. I had a cavernoma, which is a venous, obviously vascular malformation. It was on my brainstem.
Now, I was told it was going to be a 2 to 3 year recovery, and one with permanent deficits and a likely need for a walking adjunct, such as a Zimmer or a cane or a walker. However, I was back walking inside 2 weeks, and then this is me 10 weeks after, hemorrhagic stroke and 10.5 hours of surgery on my brainstem. And you'll see there that the movement was still quite slow, but it was expansive and complex. Now that was after 10 weeks, and that was it was about 6.5 years ago I actually had my stroke and surgery, and I've had constant significant improvement since then. Here's a clip where I think this was 2 years post stroke and surgery.
How you doing? It is
think it's the 3rd of June, 2019, basically 2 years after my stroke and surgery on my brainstem. Little demonstration of what's possible on with respect to recovery. The stroke robbed me of the ability to walk. The surgery robbed me of the ability to even crawl, so I had to build my movement skills back up from the very bottom. It was anticipated there was every chance that up to 3 years after my surgery I'd still be using a walker or a Zimmer frame. But anyway, here's the results of what I've been doing. How's that? So, you know, I was constantly just furthering the complexity and the skill of the movement. Although that might look quite impressive, it was still sort of slow and static movement. Whenever I went dynamic, I still would face significant challenges. Like the moment I would start to try to run, I would lose peripheral vision. All of my visual acuity would go, and running was just a massive challenge for me. And that has been the main focus of my recovery over these last 6 years. And it was in October of last year was the first time I was able to continuously run over a, you know, what might be a reasonably protracted period. I think I was able to run a constant 3 miles, probably over something like 36 to 38 minutes, which since my brain injury, that's a big thing for me. I previously wouldn't have been able to run so like more than 3 minutes without having to then walk. That's what I've been doing, sort of running and walking.
How has it been with sharing this progression? It's like progression of stages and work at all these levels with other people. How has that translated?
Well, after my own recovery was so successful, and when I clearly saw it was totally at odds with what the established rehab therapies were, I thought I've got to start helping other people, because all of this 3 to 6 months glass ceiling, and also the really unproductive way they were going about it, I thought I've got to try to help people. And so there was, through some of the Facebook communities, and I was able to help some people there. But although you can obviously see how, you know, it might sound a little fantastical what I'm saying when it's just some bloke over the internet, because it's it's not the most, it shouldn't be the most trusting environment, especially with respect to the medical advice or whatever. So that was, obviously I had to build a reputation and do that in a gradual sense. But then when I first presented at the World Congress for Neuro Rehabilitation, that's done every 2 years. The first one was supposed to be in Lyon in France, but then COVID put the blockers on that, so it was all done online, and I was just completely ignored on that one. Didn't have any communication with anyone, and for my presentation on there, not a soul turned up. And then so for the next one, what I wanted to do was to, and this is going to be an answer to your question, Dan. I wanted to to have some hard evidence of it working with other people. Because particularly because I've got what might be called a quite an athletic background. People can sort of accuse me and say, "Oh, you've just got magic genes," or "one swallow doesn't make a summer." So I for the next abstract I submitted, I put out for a group of brain injury patients for anyone who would like to come on and join the research project that I underpinned it with. And from that, we created the movement project. And I was initially supposed to be just 4 months for me to get the necessary results, which I did get. However, the results were with that impressive, or that productive rather, that we didn't have the heart to stop it and not continue it. I can show you some videos from some of the people we've been working with. This is a lady called Amber. Now, Amber, never mind 3 to 6 months, when Amber started with the movement project, Amber was she was either 12 or 14 years post her first brain injury. And I say first brain injury. She'd had 5 hemorrhagic strokes and she'd had 3 brain surgeries. She was non-ambulatory and had been non-ambulatory for those 12 or 14 years. And so this is one of the first assessment videos I took of her. And this is where Amber's just going to try to kneel up, and her movement challenges are quite visible.
Yep. Okay. So I go back.
And all she's trying to do here is just kneel up.
Yeah.
As you can see, severely challenged, and this, say, 12 to 14 years post-injury, 5 strokes, 3 brain surgeries. And so one of the techniques that I advocate, and I've advocated during today's talk, is about living your rehab and getting your movement education through experiencing solving a problem. Now, the movement problem, it's got to meet you where you're at. There's no good just trying to find the most challenging problem that you can survive at. Because if all you can do is survive, you'll just keep running the survival pattern, and you'll get better at surviving, but you won't improve. You won't build authentic skills. You need to find a challenge which is close to, but not beyond, the limit of ability. Principally where you're challenged but successful. Now, you could call that the zone of proximal development. Now, one of the most effective examples of this that I've found, both for myself personally, and you saw me climbing earlier, is the use of climbing. Because first of all, climbing is a crawling pattern. So if you can't walk, it's really important that you can crawl. And then when if you're climbing and you're using a top rope, you're supported, and you can get really expansive patterns. But also the challenge tells you how to move, and also, and this is a crucial thing, there's always an aspect of fear involved when you're first learning your climbing. So what happens is you what I call, you get out of your own way. You have a more primitive movement brain that says to the intelligent thinking brain, you get out the way, because this is serious stuff, and it tells you what you need to try to achieve to solve the problem. Now, that part of your brain will get more intelligent with respect to tasks that you're familiar and competent with, but the task, the obstacle is the way. that the task informs the movement. And so what it did, we started getting Amber to climb. Now this is 3 months into the movement project, and you saw where she was when she started. Now this is 3 months in. You can still see that a movement is really challenged, but I think it should also be quite evident where the amount of learning that's going on. This is within the zone of proximal development. You can see clearly it's an easy climb for someone who is able-bodied, but it's really, really challenging for Amber, but challenging but successful, which is the key. Just a few more seconds of this. So that was 3 months into the movement project, and I keep restating this: 12 to 14 years after she'd been told she's got all the recovery she's ever going to get, and yet in 3 months we were able to do that. Now this is 10 months on, and see if you can spot any difference. And you'll notice she's following a prescribed route. She can't just grab anything, she's only going on the black ones, although she's on a yellow one there. She's allowed to cheat though, but let's be fair.
Good, really good. Yep, that pocket. Yeah, it's really too. That was different than your beta last time, but I like it. You got it, yeah.
And one of the things, it's not just a case of improving Amber's movement skills. Can you imagine the difference this starts making to somebody's life?
Yeah, there you go.
That, like, if where she was previously for those 14 years, if you just accepted this new normal, well, you see how restrictive that is on her life, but then also how expansive this now makes her life. She climbs 3 times a week now, Amber, or certainly did at that time, and you can see the improvement in her movement quality. But all of the while, we're always aiming her rehab at the level where she's at, and always acquiring the primitive movement patterns that honour the order of dependency. And so once you become competent in crawling, we were then able to get her climbing. Once she was able to climb, we would then start working on getting able to squat, to stand, and then once you're working on standing, you've then got the option to start trying to work on walking. Now the first climbing clip was 3 months into the movement project. This was 10 months into the movement project. And then this next video I'll show you, this is Amber 20 months into the movement project. 20 months in, or 20 months after that first video you saw where she couldn't even kneel up, which was 14 years on from when she's been told she's got all the recovery she's ever going to get. And you can see she's doing a walking drill here. She's not just trying to walk, so she's lifting her knees up. So she could actually walk out in a more natural and comfortable fashion than you see in here. And the Amber's improvement is entirely representative of the improvement that almost everyone who's been on the movement project, certainly everyone who's stayed with the program and been a regular attender within, has achieved the sort of improvement that Amber's got. Now, the thing is, it shouldn't be that surprising. Learning in the neural development sequence, which is, rolling, then crawling, then kneeling, then squatting and standing. That was the way which all of us learned to walk the first time. Now, if it was successful the first time, why not give it a go the second time? What makes people think it won't work? And I consistently prove that it does. Now I can accept, although with a certain amount of reluctance, I will I won't shout anyone down with the argument that they may say there's certain types or flavor of injury or trauma that could be sustained that could prevent someone from self-ambulating. I can accept that as an argument, but what I wouldn't accept is that you can put limits on their extent to improve. And improve covers a whole range of things. It's not just whether you can walk or not. As you saw with that climbing, the difference we made to opening up Amber's life, and I suppose I'll finish up there with that. I'd sort of summarize in the big problems or what I feel are the contributors to the established protocols having such poor outcomes are going straight to walking. Walking has dependent skills. And you can't build a 10-story building and start at the 6th floor. You can't, it's ridiculous. But that's exactly what they so often try to do with that methodology. But then also, authentic movement requires authentic range of movement and mechanical relationships. Now, what that doesn't mean is you have to be a yogi to start off your rehab. You just need sufficient range of movement to become competent at the next skill you're trying to learn. And so if you're going to go through the neural development sequence, which is pretty much the milestones that the baby goes through, and I say that there's really good physical and neurological reasons why you need to go through those milestones. You get your competencies in place, and that is how you build a complex skill. You identify the least complex dependency that is missing, and you get competence in that. And then you do the same again. What's the next least complex dependency? And you work through it like that. And I've consistently proven that, everybody in the movement project had already been told that they'd had all of the recovery they were going to get. And every single one of them, we've stood it on its head.